just wanted to make sure that I do an introduction of Dr. Akinduro. Just the numbers. We're gonna spend just a couple of seconds. You know, his education. You can see he's got his BS in biology at the University of Alabama. Then went on to Morehouse School of Medicine, graduated in 2016. Then came here for residency in neurosurgery. And then in 2020, 2021, did an enfolded fellowship in neurosurgical oncology. And then this year, he's doing his research, and he is getting funded by the National Research Educational Foundation, by the AANS and CNS section on tumor research for his work in oncology, which he's going to be talking about. He's selected several things already, several awards. You can see 2017 winner of the neurosurgical Top Gun competition. This year, 2021, got his first cover in a journal Neuro-Oncology. Hopefully he'll show us some of that work, you know, and continues to do a tremendous amount of work in the literature. And this is his H index. They all know, they become familiar with the vernacular as to why this is their impact on the literature. Very early as a resident, his H index is 8. You know, his H index is 6. And just to put it in perspective, Sanjit, remind me of your H index when you graduated from residency?
It was, I believe, 14, Dr. Q.
14, good. And it continues to rise now, is over 20. And I track that for them and they track it for themselves. But that's actually how they compare. I mean, that is their impact. And remember, associate professors and full professors have an H index between 20 to 30. And so you can see how our faculty is beginning to have an impact in the literature. At a personal level, I can tell you, just gonna stop sharing that right there. At a personal level, it is an absolute pleasure to work with Olu. I think that his greatest accomplishment in life has been the birth of his son, no question. We love what he's doing in research. We love what he's doing in surgery, but it's really family with the greatest accomplishments for every one of us is every single day. We're excited to have you here, Olu, to share your work and your accomplishments to date and the future, and how you see yourself in the future as you're getting ready to go to do your fellowship with Diego Casan, who's one of the giants in the spine oncology on the world. So take it away, Olu, please.
Well, good morning, everyone. And thank you, Dr. Q, for that extremely kind and overly generous introduction. So I'll go ahead and get things started. So as mentioned, the NREF funded some of the work that I'll be talking about here. So let's get into it. So basically, just a quick outline of what we'll be discussing: good, bad, and ugly spine tumor surgery. We'll talk about radiosensitization for chordoma, talk about intratumoral therapy for some of these spinal tumors, and then what is next. So I want to keep this interactive and make sure no one's back there falling asleep on their phones and laptops. So if you wouldn't mind, I'd appreciate if you either take this number down or go to this website. And when you go to the website, it'll ask you for a code. So basically, you'll have this number and then you'll text your responses 1 through 4. So we'll get into it. So just to start it off fun and make sure everything is working with the poll, what are the chances that the Jags win the Super Bowl this year with the addition of Tebow and Urban Meyer? I'm interested to see what you guys think. So like I said, you can take this number and all you have to do is text 1, 2, 3, or 4 to that number, or you go to swiftpolling.com and then you just type in this number that they asked for. So I'll give you guys a few, about 20, 30 seconds. I'll see if we can make sure this thing is working.
So Olu, we just texted to that number, right?
So let me see.
Oh yeah, there you go, there you go.
Okay, there it is. So let me see. For some reason, it wasn't showing up here. There it is. Oh,
there you go.
All right. Oh, nice. So we got a few believers. I'm surprised anyone said definitely. All right. So I'll pause that and we'll keep it moving. All right, so the good, bad, and the ugly of spine tumor surgery. This case, I would consider the good. I'm not gonna show everything, just go over the highlights. This is a case I did with Dr. Nautmeyer, and we got it published. 78-year-old man, he had some pain, especially severe radicular pain. And here, as you can see, this T11 lesion on this axial view, you can see some compression of a spinal cord, a lot of bony erosion. So he ended up going, having a biopsy, found out it was hepatocellular carcinoma. He had a T11 nerve block, which provided some relief. So we took him to the operating room so we can try to debulk the tumor, diminish the amount of pain he was having, and also prevent him from getting weak from the spinal cord compression. So I think Dr. Talk is the one who actually did the embolization for this case. And I'd like to think it made surgery a little bit easier for us. So I'll just quickly go through this. Here we did a standard dissection, placed our screws, and then here we placed a temporary rod while we did our laminectomy and removed the pedicle on the contralaterals on that side there. There you can see, interestingly enough, some bile within the tumor, and there's the nerve root that was actually causing this pain. So we transected that, and that also gave us access to the to be able to perform our corpectomy and have enough space to place our graft. So here I'll just show us placing the actual cage. And then here you can see the post-op images. Everything went great. His pain, his radicular pain went away. He was really happy. Everything was perfect. But unfortunately, as the nature of the beast, his tumor, eventually came back. So this case I would consider bad. I mean, horrible. This patient, actually, I remember her vividly because I was on call when she came in. She had pretty severe lower extremity weakness, progressed. I mean, over the course of just 2-3 days in the hospital, she was completely paraplegic, Asia A. She had a biopsy which showed that this was a high-grade glioma, H3K27M mutant. She had radiation, but unfortunately, she passed very shortly after the actual diagnosis. And we actually published a series of these, a multi-center series of these in JNS Spine this month. And we found, interestingly enough, that this mutation is actually slightly protective in an older population. So if she were, maybe 30, 40 years older and she had this H3K27M mutation, that actually may have been a slightly good thing in this situation. Of course, these tumors are horrendous, and they are uniformly, unfortunately, fatal with pretty fast progression. But it's interesting how the mutation acts different in adults versus how it does in kids. So hopefully someone really smart will figure this out in the lab and come up with some better ways to treat these patients. So now to get into the ugly. So this was an 80-year-old guy. He had progressive neck pain, myelopathy. He had a previous thyroid cancer with some radiation. He had a decompression that we performed for this lesion. I'll show you here. There you can see tumor in the posterior elements and obvious compression of a cervical spinal cord with T2 signal change extending rostral and caudal to the lesion. So this is why I call it the ugly. So of course the patient needed radiation, and in the situation where he had past radiation, he unfortunately presented with a wound dehiscence, which is just one of those unfortunate things that you see in these situations. So there's got to be a better way to do this. There's got to be a better way to treat these patients, or something that can be done to help these patients even more than we are now. So there's been a huge paradigm shift over the course of the last couple of decades in terms of going from no real surgical options for many spine tumor patients, like patients with METs, where, if you had a spine MET, back then you may not even operate on the patient. And then it wasn't really until the PATRO trial that people realized that for these patients that do have some spinal cord compression, they're going to benefit from having resection of their tumors. So then you went and entered an era where you're doing maximal resection, you're taking out everything, these big, huge surgeries. And now we're really entering an we have entered an era where more minimally invasive procedures are becoming more standard. And that goes from deformity to degen to spine tumors. where you can now just use a tube and just decompress the spinal cord and place screws percutaneously, and patients leave the hospital quicker. It's better for everyone. And one of the main reasons why we've been able to offer patients with spine tumors things like this with more minimally invasive procedures is because of the advent of some of these better radiation delivery strategies. SBRT is an example of that, where you can deliver a higher ablative dose with better conformality and diminished spillover into the the surrounding adjacent structures. So that introduces this concept of separation surgery, where you can just do a surgery to decompress the spinal cord, and then everything left can just be radiated. And obviously then you can just use a tube, decompress the spinal cord, perc screws, get the patient out within a day or two. So still, there's got to be a better way to do this. So now that patients are living longer, the issue is becoming, we have to pay more attention to how they do in the long term. Obviously, in the past, a patient with a MET isn't going to live very long. So unfortunately, it didn't really, I wouldn't say it didn't matter, but you wouldn't see the clinical sequela of non-union, for example. So this is some forthcoming data we have not published yet. So this is the first time anyone has shown that these newer advanced radiation technologies, they do actually result in better fusion rates and lower incidence of clinical pseudoarthrosis for these patients. So this is huge. I mean, moving forward, these patients are having better targeted therapies. They're living longer. So we have to pay more attention to how they do after just the initial surgery. But the question still remains, can we do better? So let's do another question. So let me switch over to this, start that. So here, what do you guys think will be the next major change to improve outcomes for spine tumor patients? I'm interested to see what you guys think. So systemic targeted therapy, intratumoral targeted therapy, innovative surgical techniques, and then advanced technology like robotics and VR. So it's a race between intratumoral therapy and VR. Nice, I like it. So I'll give maybe 10 more seconds to get some responses in. And thank you guys for participating.
And thank you, Olu. This is beautiful what you're doing with this. Keep teaching us, because we all want to use the system.
Yeah, I'll show you guys how to use this one. Unfortunately, Mayo doesn't allow add-ins, because there's a way to embed this into your PowerPoint, but Mayo doesn't allow it, so I'll have to work on that. But either way, it's a great opportunity to get some crowd participation. So that's good for now. We will move on. I'll pause that one. So great. So you guys believe in some of this intratumoral targeted therapy. That's great to hear. So I'm going to switch gears a little bit, but I'm going to tie it all in. So Chordoma is what I've been working on this year, and what I'm going to be working on this year, rather. Actually, first kind of became interested in Chordoma back in medical school. I remember I was rotating one of my sub-Is, and I was in clinic with a well-known spine surgeon, and we just saw a patient with Chordoma that had come back for the 4th time at this point. And I'll never forget, he said Chordoma is the bane of his existence. He felt like no matter what he did, it always came back. So why is that? I mean, Chordoma, it's the most common primary malignant spinal bone tumor. And there's a discrepancy between the histopathologic characteristics versus its actual clinical behavior. It's a tumor that if you leave even the tiniest cell, either in the surgical bed or even along the surgical tract, you'll have a recurrence. And it doesn't respond well to any therapies, really. So really, en-bloc resection with wide surgical margins is the only way to potentially cure these patients. And it's got to be at the first surgery. But the issue is, of course, you have the tumors in the skull base, where you have the carotid artery and all these other neurovascular structures surrounding. I mean, you're not always going to be able to get a non-block resection. It's just impossible in many of the situations. And that's the example here. As you can see, this is a paper we published not too long ago. And shout out to Tito for this beautiful figure that was featured in a June edition of Journal of Neuro-Oncology. But essentially here, we showed that, en bloc or even an intralesional gross total resection, you're going to have better outcomes for these patients. But unfortunately, for example, in the cervical spinal cord, in the cervical spine, you have the spinal cord itself, you have the vertebral arteries, you have the esophagus, trachea, all these structures. So it's not always going to be possible. So what can be done for the patient that you're not able to get this, immaculate resection? And unfortunately, there are no FDA approved agents for treatment of chordoma, nothing. So, I mean, a big part of that is because things don't work that well. So the question is, why do these therapies not work that great? So this is another paper we published in Targeted Oncology. Here, this is a figure basically showing some of the previous and ongoing trials and some of the drugs and targets for chordoma, that are being used for chordoma rather. And some of them, like imatinib, there's been at least 3 clinical trials using imatinib, and none of them have shown very good results. Some of the newer therapies are having a little bit better results, but still nothing is working that great. So the question is why? And a big part of that for chordoma, at least, is the concept of cancer stem cells. So these are a population of cells that have the ability to see new tumors, self-renew, and resist anything you throw at it. They've been found in tons of tumors: GBM, lung, breast, urothelial cancers, osteosarcoma. And the hallmark of these cells is that they have the ability to self-renew and resist anything, anything that you throw at it. So why is it that these stem cells have the ability to, just continue to grow and replicate despite what you do? So you have to think about the Hippo pathway, which is really the master regulator of cell growth and proliferation. And brachyury is actually positive in all chordomas. That's a classifying feature of chordomas. So the brachyury YAP regulatory axis is what maintains stem cells normally in the neuroaxis. So that pathway is severely upregulated in chordomas, and that's a big part of what drives their growth and resistance to radiation and chemotherapy. And it does the same thing in tons of other tumor types, as you can see below. So my goal is to sensitize these tumors to radiation. So we have to just quickly take a look at the DNA damage repair cascade and get a basic understanding of what goes into it. So radiation, it enacts its damage by causing double-stranded and single-stranded DNA breaks. Then that initiates this large cascade of events known as the DNA damage response pathway. So the kinase ATM is a big part of that initial recognition of the double-stranded DNA breaks, and then that sets in motion everything else. You got tons of effectors, but one of the main checkpoints is ATM phosphorylating gamma H2AX. Here, I'm not going to go into all these details, but here are just some of the major key regulators that I've been looking at over the course of the last couple of weeks since I've started this new work with Chordoma. So ATM, ATR, PARP, RADS1, RPA1, and there's tons of other ones that I'm going to be looking at as well. So how am I going to actually, do this? How are we hoping to sensitize these tumors to radiation? So verteporfin is a drug that's actually already FDA approved for macular degeneration, which is good. So we know it should be safe, but it's been found to have robust inhibition of YAP. So here's a figure from some of our work, which is still forthcoming. Really, the main thing I want to show you guys here, if you take a look at where verteporfin acts. So YAP itself can't actually enact all of its effects. It needs to bind to TEAD, and that's where verteporfin acts. So verteporfin basically prevents it from binding to TEAD. It just inhibits that interaction, and inhibiting that interaction essentially shuts down YAP, and it can't do what it essentially needs to do. And here also you can see all the various things that YAP is involved in, from cytokinesis, cell cycle progression, DNA replication, cell adhesion, just a plethora of things that this pathway is involved in. So my hope is that we can shut all of these things down by inhibiting YAP itself. So this is a nice paper that was published. Basically, looked at PP2A inhibition to enhance radiation sensitivity in chordoma. And when I saw this, my thought was, okay, can we do this plus more? Because YAP has the ability, which I'm now seeing with some of my recent research, to inhibit PP2A as well as a plethora of other radiation-related genes. So my hope is that we can do this, but to a greater degree. So this is some of my previous work, basically just showing that YAP or verteporfin does work. It does inhibit YAP as well as tons of YAP downstream effectors in chordoma. So here you can see things such as CTGF, things such as KIF are involved in motility. So obviously it works is what I'm showing here. And this is some of the work we've collected over the last really just a couple of weeks, basically showing that now really looking at the whole DNA damage cascade. So for example, this experiment here, we treated the cells with verteporfin and then treated them with radiation. So radiation is what's gonna cause the DNA damage response pathway to increase, as you can see here. So 4-gray radiation, this is the control. You can see a nice expression of gamma H2AX. And then with increasing doses of verteporfin, you can see it completely shuts it down. Same thing with PARP, and then tons of these other effectors such as ATR, ATM, RADS1, and RPA1. So this is really encouraging. I mean, it's only really been a couple of weeks that we've been looking at the whole DNA damage response pathway, and it looks like verteporfin has the ability to basically shut it down. So still a lot more experiments to do, especially with some of this gamma H2AX. We're going to do flow cytometry and a lot of other things. And of course, we have the animal work. So that's all the in vitro data. Now I'll talk a little bit about some of the in vivo work in animals. So here you can see these microparticles. Like I mentioned, this is intratumoral therapy. So below you can see the size of microparticles is larger than nanoparticles. So nanoparticles, you really think about systemic delivery, but the thought here is, okay, we're surgeons. We have the opportunity to, at the time of surgery, leave some, microparticles. Then the other thought process is with, systemic delivery, you also have to worry about systemic effects. If you have something that works really well and you can deliver it in the actual tumor, you minimize the side effects that the patient's going to see with, because end of the day, there's going to be deposition of whatever the compound is into other organs. So these microparticles have the ability to allow sustained slow release of the drug over the course of time. So here, just a pictograph of experiment we're going to be doing. Basically, right now, we're initially going to use a cell line called JHU7, but we end up using another cell line because it grows a little bit faster. So we recently transduced those with something called lentivirus. And now we're just growing the cells enough to where we have enough cells to inject in all the mice. But essentially, we'll inject them subcutaneously, wait for the tumor to grow, and then there'll be different treatment groups. Some will be treated with particles, some with naked particles, some with systemic delivery of verteporfin, and then we'll radiate them and see, if the microparticles can make the radiation response much more robust. Here, I'm not going to dwell on this, but just kind of to show you some of the different groups. So like I said, there'll be a group with systemic injection of verteporfin, a group with naked particles, and then a group with the actual particles. And this is some nice previously published work by the Quinones lab, basically showing that these particles can enhance the sensitivity of GBM to radiation and diminish their growth. So I'm hoping that we can replicate some of this data for chordoma. So chordoma is pretty rare overall, but spine mets are extremely common. I mean, you see spine mets all the time. at least 20,000 new cases every year, and that's old data. So by now, it's got to be much more than that, especially since these patients, like I said, are living longer. So that's more time for them to have more spine metastasis. So when you think of metastasis, it's really just various alterations and mutations that lead to this tumor cell that has the ability to enhance or to migrate much better. It doesn't adhere very well. And then also these cells have better clonogenicity in the new environment. So in this new environment that they migrate to, they have the ability to form new tumors. So there've been plenty of studies that have shown that, you know, these spine mets have a very different properties and genetic composition than the actual tumor of origin. So the question is, why is it then that there have been no, you know, any therapies that have been approved for these patients? So my goal is to change some of that. So this is some of the work I've done previously. This is in 2 different metastatic spine cell lines of this, so lung as well as breast, 2 of the most common. So here basically just showing that verteporfin has the ability to inhibit the clonogenicity of these spinal tumor cells. Here basically showing that it works very well in terms of diminishing YAP as well as YAP downstream targets. And here basically just showing that verteporfin has the ability to sensitize these tumors in vitro, at least, to radiation. So of course, all this has to be replicated in vivo, which we're working on now. Actually, we have some mice arriving tomorrow, so we're gonna get things started. So I want to show you guys this again, not to make you vomit, but just to transition into, just to show you guys a little bit of work being done by the Tribe Lab with Dr. Sarabia Estrada, Dr. Forte, and plenty of people involved: Francisco, Ricardo, Carla, Paul, Abdullah, and a couple of students. This is, I thought this was great, just because the concept here is that they're using mesenchymal or adipose-derived mesenchymal stem cells, and the goal here is to try to protect these, protect from radiation-induced skin damage. So I'm hoping that therapies like this can help patients like this, so we don't have to deal with these kind of things in the future. So there's a lot of different work being done. I just kind of wanted to show you guys some of that. So what do you guys want to see? What would you guys like to see in the future for spine tumor patients? This is open-ended. So you can just type whatever comes to your mind. It can be, anything. I'm interested to hear from you guys. Give maybe 30 seconds for this. Nanotechnology, I like it. I like it. We got a smart group here. Beautiful. Catheter delivered therapeutics. I like it. And what I like about this is these are all things that we can now, think about and push forward. So, we can discuss all these things in the future. So I love it. Scaffolds with stem cells. It's beautiful. And I'll give maybe 10 more seconds for this. Probably nanoparticles. Okay. Carbon therapy. Nice. Yeah, we're getting the carbon proton-based. I think it's coming up, to my understanding, I think next year. Regenerative approaches. Yes, I like it. I like it. You're too kind. Awesome researchers like you. Thank you guys. Thank you guys. This is beautiful. All right, so let's keep it moving. So a lot of great responses there. So a lot of smart people in the crowd. So we got a lot of ideas. So let's do it. Why not? Let's move this thing forward. So what's next on the horizon for me and some of my work? The next step is an orthotopic model. So here's a pictogram, just give an example of what that's going to look like. This is some previous work by Dr. Sarabia Estrada. Basically, my plan is to do this for chordoma as well as spine mets, where we grow the tumor in the vertebral body itself. And the word orthotopic basically means that you're growing the tumor whatever the native location would be in humans. So that's one thing. And then, of course, we got to work on GMP grade particles. And that's basically just baseline pharmacological grade that these particles have to be for the FDA to approve their use in humans. So that's another step that's important. You don't want to skip over that, because that then transitions you into clinical trials, which is also one of my goals. You know, you got to take it from the lab, you know, and then transition it all the way into to humans. And of course, that takes time and money and energy, but you know, hopefully we can get all three of those things and push this thing to the next level. So thank you to everyone involved. Of course, NREF for sponsoring this. The Quinones Lab with Dr. Q as my mentor, and great people like McKinley, who has helped me a lot with some of these experiments. You can see her right there in the front. And of course, my family for the support. So thank you guys. And I will take questions as we look at the beautiful Jacksonville horizon. Thank you.
Beautiful, beautiful talk, Olu. Absolutely inspiring. You can see a lot of the comments. You know, I see some questions already by Dr. Jacob, but the first question, and then I'm going to pivot to Dr. Jacob. The first question is Adamol already a year old? I mean, he looks like huge, and he's like completely moving his neck all the way around. I'm just surprised, you know, because I think he's only like a month old.
Yeah, he's I think he's just hit 2 months today, or yeah, it should be 2 months now.
Great.
Almost.
Beautiful. Great. So Kurt, you want to ask your question?
Sure. First of all, that was a wonderful talk, very educational and well presented. And I think that that's an exciting area you're moving into with a lot of grant opportunities. That's great. I guess these are probably theoretical questions, but if you have any information, it'd be great. Do you think those concentrations you show that are active in vitro, you think those concentrations will be achievable intratumorally in the chordomas, because they're, you know, so solid and everything, low vascular supply? In the humans, can you get those concentrations into tumor? And is there proof that you can engage target, you know, within the tumor? Scientifically, that would be important as well.
Yeah, so that's a great question. So in terms of getting that concentration in the tumor and having it actually, like you said, these are solid tumors, that's something that we're still going to have to study a little bit more. Plan on doing some experiments where we have a solid, you know, chordoma, maybe an animal, and we're going to basically be looking at the actual spread of the microparticles within the actual tumor. So that's an excellent point, but that's something that we still kind of need to look at. But at least from some of the early data, I'm thinking that it will, but this is something that we still have to kind of see, especially for the really large tumors, like you mentioned.
Yeah, some of the things I'm thinking about is some of the chordomas I've taken care of, they can be metastatic or they're really not operable. So that would be a physical challenge for you to put particles within the tumor, unless you combine it with immunotherapy or something that would act as a bystander. But systemic administration, if you could get concentrations of your drug in there in those patients, that would be great.
Yeah, so systemic therapy is something that I've thought about, but at least for right now, this year, I wanted to focus on intratumoral therapy just because that's more applicable to me as a surgeon. But for example, one option would be for the inoperable tumors to use X-ray guidance and use a needle, and then we can actually place the microparticles into the tumor, wherever it is, using either X-ray guidance in the OR like we do, or use CT guidance. So that's one option to still be able to deliver the particles into the tumors, no matter where they are, even for these patients with Mets. And then the systemic delivery, that's going to be something down the line that I'm hoping to look at, because the main issue is getting the or the nanoparticles to find a way to hone them to the actual, the tumor. And that's something we haven't been able to figure out yet. And I haven't seen any good literature for it, but it's definitely something I'm planning for the future.
Awesome.
And to follow up, Kurt, I think this is an amazing question. So the idea is do the surgery, disrupt the blood-brain barrier, put the nanoparticle, the microparticles there, and then give the radiation. But the reality is the microparticles that Olu showed that we work on is an older generation. We have some new microparticles that are pegylated that are able to penetrate a little bit more. I'm not talking about much, maybe 2-3 millimeters, but that's enough sometimes because that's the remnant that we live in these tumors. In regards to the systemic delivery, we do have some nanoparticles that are stable in serum. But what Olu just said is how do we target them? That's the next challenge. At least we know we can put them in the system and they don't get degraded and they don't just dissolve immediately. And the next frontier is to target them.
Yeah.
I think that this is great work that Olu is doing, and I think your questions, are very relevant. Hopefully, we'll tackle them over the next 3 to 5 years to come.
Thank you.
Wonderful. We have a few more questions. Raise your hand if you want to. Looking at the chat, I was trying to keep track of the chat. Right here. One of the questions that I was getting text about, Olu, is you mentioned the use of stem cells. Can you maybe elaborate a little bit more as to the vision for the future as to how stem cells can potentially play a role here? And then I'm going to pivot to Selby. Go ahead, Olu.
Yeah, so that was really highlighting some work that's being done by Dr. Forte and Dr. Sarabia Estrada. So I don't want to go into too much detail because it's not my work.
Gotcha.
So they can probably talk to you guys a little bit more about it. But the overarching concept is to use, like I said, fat-derived stem cells. And the goal is that they would have a protective role in these patients or, right now in animals after radiation. Right now, it's mostly kind of in the pilot phase. They did an experiment where they worked with immunocompromised rodents, and they also now have done it with immunocompetent rodents to see which model would be best for doing the experiments moving forward. So it's really in the infancy of its work, but really just kind of showing you guys what's on the horizon.
Beautiful, beautiful. Selby, take it away.
Great work, Olu. Really fantastic presentation. So, my question for you centers on specifically spinal metastases, and that, unlike metastases to soft tissue like the brain or other parts of the body, metastases to the spine involve, spinal column that provides structural stability for the rest of the body. So even after eradicating the tumor with the tumor-targeted therapies, you still need to provide that stabilization. Any thoughts on how this might impact treatment of spinal surgical oncology overall?
Yeah, and in particular, in response to your comment about stability, I mean, of course, if you have to fuse these patients, the paper that I showed you guys that I'm trying to publish now, we found that these targeted therapies or this targeted radiation will allow these more likelihood of fusion for these patients. But as far as how the particles are going to interact with the hardware, that is kind of still to be determined. But my hope is that if anything, it allows for better fusion and doesn't, or at least doesn't have any adverse effects on the patient in that context. But to my understanding, there really is no effect on the actual fusion rate. But like I said, these are all things that really have to be determined.
Great, thank you.
Beautiful, thank you. Well, thank you, all. A beautiful presentation, testament of all the work that so many people are doing, the stem cells with Rachel, they're doing in the skin and the brain, clinical trials, GMP, a lot of amazing stuff in the pipeline. And I can tell that, when I look at Kurt, he gets excited, Dr. Jacob, because his dream has always been in, transferring the knowledge from the laboratory to the patient. And I think that you have the pipeline already with the GMP nanoparticles, stem cells, 2 clinical trials already being used, stem cells that Andres is leading. So tremendous amount of work. I just want to mention that at one point we almost had 80 people sign in some of those rooms, and some of the people have several people. So I estimated that we almost had about 100 people, anywhere between 7 and 8 in the morning, listening to your talk. So tremendous outreach, tremendous interest on the work that all of you guys are doing, all the residents, and that you're leading for your own work. So thank you. Have a great week, everybody. Looking forward to the rest of the week, and we end up with Friday with more case presentations. All right.
Perfect. Thank you,
Adios.
everyone.
Bye-bye.